A very good evening to everyone. Welcome to episode 8 of the Hot Topics in Cardiology webinar series organized by the APSC. This series today, this episode is done in conjunction with CSI Asia Pacific. I'd like to thank Edwards for supporting us with an unrestricted educational grant. So today, co-chairing with me is Dr. Mann Chandavimol, who's the president of CIAT from Thailand. And we have a very distinguished panel of panelists. We have Dr. Kiriyama from Japan, as well as Dr. Rajaram from India. We have two speakers who are going to talk to us on early intervention in asymptomatic severe aortic stenosis. We have Dr. Jessielyn Sia from Philippines, and talking to us about TEVI for aortic regurgitation. We have Dr. Ivan Wong from Hong Kong. Just some housekeeping rules. This contents are copyrighted by the APSC. Later on, after each lecture, which will be about 20 minutes, we have about a 10 to 15-minute discussion. If you have any questions that you would like to ask us or the speakers, please post them in the Q&A section. So the icons at the bottom of your screen. And just a quick shout out, in 2 weeks' time, we have APSC in Taipei in next week. So for those of you who are joining us, we look forward to meeting you. And so without further ado, we are going to segue into our first talk. Once again, the first talk is on early intervention in asymptomatic aortic stenosis, brought to us by Dr. Jessielyn Sia. Jessielyn, over to you.
Can you see my screen?
Yes, we can see your screen.
Okay, so good evening, everyone. So first of all, I would like to thank the organizing members of this session. It's such an honor to be with you tonight. So today I'll be discussing early intervention in asymptomatic severe aortic stenosis, shifting the threshold. So I have no relevant disclosures. So let me start with a familiar patient. It's a 70-year-old male with a severe aortic stenosis with an aortic valve area of 0.7 square centimeter, maximum velocity of 4.5 meters per second, and ejection fraction of 60%. So our first question is, do you have any symptoms? And the patient would say, Doctor, I'm fine. And for decades, our response was to observe. But the key question is, what if by the time symptoms appear, we are quite late and the ventricle is already damaged? So in order to understand why the threshold is shifting, we need to understand the natural history of aortic stenosis. So this classic Braunwald curve reminds us that aortic stenosis has a long silent phase, followed by a steep decline after the symptoms. These are angina, syncope, and heart failure, which mark a dramatic fall in survival. So the real challenge is not identifying the symptomatic disease, but it is recognizing the danger during the silent phase. So the word asymptomatic can be misleading because usually patients adjust the symptoms. They slow down, avoid exertion, or normalize their limitations. Meanwhile, the left ventricular hypertrophy, fibrosis, and diastolic dysfunction may appear to be developing even before the onset of symptoms. So the absence of symptoms does not always mean the absence of disease. So what changed? So there are two things. First, we understood that the myocardial damage begins before symptoms. And second, randomized trials started to challenge the idea that waiting is harmless. And now, what's the pathophysiology on how cardiac damage secondary to aortic stenosis? And what's the rationale for the early AVR? So as afterload increases, the left ventricle compensates through hypertrophy. But over time, this creates a supply-demand mismatch, causing myocyte injury and fibrosis. So diffuse fibrosis may be reversible, but the replacement fibrosis is not. And by the time ejection fraction falls, myocardial damage may already be advanced and eventually irreversible damage. Now, this emphasizes the importance of timely intervention. Now, this staging of cardiac damage might help us in selecting patients for early AVR. And this is why staging cardiac damage is so important. Aortic stenosis starts as a valve disease, but it doesn't stay there. It progressively involves the left ventricle, the left atrium, the pulmonary circulation, the tricuspid valve, and eventually the right ventricle. And the more advanced the damage, the worse the outcome, even after valve replacement. So this five-stage model helps us understand this progression. So stage 0, which is purely valvular with no cardiac damage, this is the ideal window for intervention. Stage 1, where left ventricle damage begins, presence of hypertrophy, diastolic dysfunction, and even with normal ejection fraction, myocardial injury has already started. Stage 2, which is the left atrial involvement, where in the presence of atrial fibrillation, left atrial enlargement, functional MR, the disease is now affecting the backward circulation. Stage 3, which is in the presence of pulmonary hypertension and tricuspid regurgitation, now it's called a cardiopulmonary disease, and outcomes begin to decline. And stage 4, which is the right ventricular failure or dysfunction, and at this stage, recovery may already be limited. So the key message is, by the time symptoms appear, many patients are already in stage 2 or 3. And that's where the paradigm shift. We wanted to shift from waiting for symptoms to identifying the early cardiac damage. And the move towards early TAVR began with observational data and was later tested in randomized controlled trials. So observational studies showed that most patients with asymptomatic severe AS develop symptoms within 1 to 2 years, and with approximately 1 to 2% annual mortality risk, even symptoms appear. More importantly, even the valve replacement was consistently associated with better survival, fewer symptoms, and less heart failure. And this raised a key concern that maybe waiting for symptoms is already too late. And the rise of the randomized controlled trials that include Recovery and Avatar, which evaluated early SAVR, and Evolved and early TAVR trials, which brought myocardial damage guided and transcatheter strategies into the discussion. So let's start with the Recovery trial. This study studied asymptomatic patients with very severe aortic stenosis. Now, early surgery significantly reduced cardiovascular death, all-cause mortality, heart failure hospitalization, and importantly, most patients in surveillance group eventually required surgery. So waiting did not avoid the intervention, it only delayed it. So the key message here is, in very severe aortic stenosis, waiting doesn't avoid intervention. It just delays it, and often after the patient has already worsened. And this was followed by the Avatar trial, which looked at the truly asymptomatic severe aortic stenosis. And importantly, this was confirmed with exercise testing. And patients were randomized to early surgery versus conservative management. And what did they find? Early surgery reduced major adverse events and heart failure hospitalization. However, unlike the recovery, the mortality benefit was less clear, but the message remained to be important. Even truly asymptomatic severe aortic stenosis can progress clinically. And here we saw that the early surgery reduced events and heart failure, but the mortality benefit was less clear. So this field evolved again, which is called the Evolved trial. This shifted the focus from valve severity to myocardial damage. So Evolved asked a different question. If patients already show myocardial fibrosis, will early AVR improve the outcome? So the primary endpoint, which were death or aortic stenosis-related hospitalization, was not significantly reduced. But early intervention decreased the heart failure symptoms, the repeated hospitalization, and this tells us that selection matters, and even when survival is unchanged, early intervention may still matter because it reduces the clinical deterioration and improves the patient trajectory. Now, after those SAVR trial and the fibrosis-guided strategies, the next question was whether a less invasive approach could safely shift the intervention earlier. So this is where early TAVR becomes very important. Early TAVR randomized asymptomatic severe aortic stenosis patients to TAVR versus clinical surveillance. And early TAVR showed a reduction in the composite of death, stroke, and cardiovascular hospitalization. The benefit was mainly driven by fewer hospitalization and prevention of clinical deterioration. However, the survival benefit or the all-cause mortality remains to be less clear. So in the early TAVR trial, they also studied the clinical surveillance group, and they found out that in the clinical surveillance group, patients did not simply remain to be stable. Many progressed before eventually undergoing AVR, and they can be classified into 3 stages. The asymptomatic group, patients appear stable, but many are already on a trajectory towards intervention. Progressive valve syndrome, the early warning phase, mild symptoms, rising BNP, increasing heart failure medications, and subtle, often they are underestimated, but the compensation has already begun. The aortic valve syndrome, the acute valve syndrome, patients present late and sick, heart failure, syncope, arrhythmia, and repeated hospitalization. And this is where it becomes clinically very real, very important. In the surveillance group, most patients don't stay stable for long. At a median of just 11 months, many are already requires aortic valve replacement. And look at the trajectory. 26% needed a valve surgery within 6 months, 47% by 1 year, and 71% by 2 years. But more important than this is when they, not just when they convert, is how they convert. About 40% presented with acute valve syndrome. They didn't gradually decline, they crashed. And the remaining 60% had progressive deterioration. And few were truly asymptomatic at the time of intervention. So the message is clear. Surveillance is not passive. It demands vigilance because the window for safe elective intervention can quickly become a moment of decompensation. And these are the key findings from the early TAVR trial. Over a median follow-up of 3.8 years, early TAVR reduced the primary endpoint by about 50%. Patient also did better clinically with improved symptoms and favorable cardiac remodeling. In contrast, the surveillance group often presented late, many with acute valve syndrome, which was linked to a worse outcome. Importantly, early TAVR was safe with no increase in mortality or stroke. So the message is simple: intervene earlier in order to prevent the crash. So when you combine these trials, the pooled meta-analysis of the 4 mentioned trials showed a trend towards a lower all-cause mortality and cardiovascular benefit with early treatment. So the signal is consistent, but we still need careful selection and longer follow-up. So there's a sub-analysis of the early TAVR trial. In asymptomatic severe AS, a higher NT-proBNP and troponin levels identify patients at high risk of adverse outcome. However, the benefit of early TAVR was consistent regardless of the biomarker levels, suggesting that the markers alone should not dictate the timing and did not predict when the patient would deteriorate, nor they reassure us that a stable course could be expected with surveillance. And across each group, early TAVR remained to be beneficial, with lower stroke risk in younger patients and greater reduction in heart failure in older patients. And more evidence is coming, and more evidence is needed. So the DANAVER and ECAS trial are underway. These trials will refine who will benefit the most. The future question is no longer simply symptoms or no symptoms, but which asymptomatic patients are already biologically decompensating. And these are the current and evolving management strategies for patients with asymptomatic aortic stenosis. In 2025 ESC guidelines, it states that intervention is a class 1 indication for asymptomatic severe AS with symptoms during exercise or LV ejection fraction of less than 50% and no other cause. And guidelines are also moving. The ESC 2025 goes further by allowing early intervention as a reasonable alternative in selected low-risk patients. So how do we apply this in practice? This is the real threshold shift. The key is to identify the patient who is not truly low risk. High-risk features included very high velocity, rapid progression, elevated BNP, severe valve calcifications, abnormal exercise stress test, reduced global longitudinal strain, or LV ejection fraction drifting below normal. So these are the patients who already be silently decompensating. So the benefit of early intervention is preventing irreversible myocardial damage and reducing heart failure hospitalization. But we must balance this against stroke, arrhythmias, vascular complications, valve durability, coronary access, and future reintervention. So early TAVR must be a lifetime strategy. So future perspectives, short of a crystal ball, we have to make use of the tools available to us in order to identify patients who are likely to have heart failure first. So this will boil down to risk stratification, availability of history, clinical judgment of the physician, liberal use of imaging and biomarkers, or maybe even an AI-based prediction in order to help piece together the puzzle into a clearer picture. Or to play the devil's advocate, just replace the valves in all of them. There seems to be proper indication for it anyway, but the goal here is early intervention is not just about doing TAVR sooner. It's about choosing the right first valve strategy for the patient's lifetime. So in conclusion, aortic stenosis is a progressive myocardial disease. It's not just a valve problem, and asymptomatic does not mean low risk. By the time symptoms appear, myocardial damage may already be underway, and that's why early intervention is gaining ground. In selected patients, it is safe, it reduces heart failure hospitalization, and improves the functional status. Though clear mortality benefit is still evolving, and every decision must still remain to be patient-centered, heart team-guided, and focused on a lifetime valve strategy. So traditionally, the established moment of intervention in aortic stenosis has been clear. Once symptoms appear, we intervene. But the paradigm is evolving. We are now looking earlier into the latent phase, where a potential sweet spot may exist, a window where intervention is still safe, can preserve myocardial function, and may improve outcomes though this remains an area of ongoing study. So the paradigm shift is this. So we are moving from the treating the valve after damage has occurred to protecting the heart before that damage becomes irreversible. And with that, I would like to thank everyone for your kind attention.
Thank you very much, Jessielyn. It's Mann here. Maybe we can get some discussion and you can chip in as well. My question perhaps to Hiroyuki and Raj is that with this current evidence, have you changed your practice? Have you guys starting doing TAVI or AVR in asymptomatic patients? Maybe start with you, Raj.
Yeah.
Okay.
Sorry.
Oh, sorry. Yeah.
Sorry, you go, Professor, you go, and then I'll take. Yeah, please.
Hiro, you
okay.
go ahead first. Yeah.
Hiroyuki,
Okay.
so sorry. Yeah, Hiroyuki first. Thank
Sorry.
you.
I'll go ahead. So, thank you for a great presentation. So, I answer the first question. So, the some trials for asymptomatic AS patients changed partially our clinical settings. So, but we have to consider the result of this trial carefully. So, these trials include younger patients and very low-risk patients. So we have to think about the second valve strategy, like valve or intervention. So these trials assisted that we can do the TAVR for asymptomatic patients. So we now do TAVR for very high age patients with asymptomatic. So we don't need to think about re-intervention for those patients. So so when the severity of AS become more severe, so we aggressively do TAVR for those patients. But when we think about more younger patients, so the intervention should be considered carefully. So those trials are very short-term results. So we have to be more carefully for do TAVR or SAVR for those younger patients or low risk patients. That's my comments.
No, that's a great point. How about you, Raj? How do you take on this?
Thank you, Mann, and thank you, John. Obviously, the indications in terms of the TAVR versus SAVR hasn't changed. It's been the same, practice-wise. In terms of how we treat with this asymptomatic severe AS patients, now the evolving and the sort of coming up on future evidence, giving us more confidence that we can treat these patients early, so that we don't need to treat them when they come with an acute valve syndrome or acute sort of failure, when the procedural risk is significantly high. The way I see it and the way practice changed is the early TAVR has showed that majority of these patients are getting converted to TAVI or definitive treatment in a short period of time, within 6 to 12 months. And also majority, when they come in acute heart failure or acute valve syndrome, the risks are considerably high compared to when you do it in an elective situation. So I'm telling the patients that first the proper assessment, and if they're truly asymptomatic, if they're able to do a treadmill, we are doing a treadmill to see the blood pressure drop. If they're not able to do treadmill, then calcium score is the next criteria I'm using. If there is a high calcium, then we take it. If there is still doubt, then you add the other markers like the BNP as well as the sort of LG. So these are the sort of stages we're taking. And most of these patients will become a TAVR candidate when you go through this algorithm and 4th or 5th of this added. Very few patients like don't have this criteria and still remain asymptomatic, maybe less than 10%. That's a fantastic presentation. I think you summarized everything very well. Thank you.
Yeah. So since there is no mortality benefit in these early TAVI trials, is it bothering you in some sense that do you think that it might do you need to see mortality benefit to be convinced or to move this up to level 1 recommendations?
No.
Or do you think it just because of the conversion is quick, refer time is short in real practice? Maybe that's not the case.
I think her Jessielyn slide showed me the first 2 groups are class 1 indications when they are asymptomatic, but when you fall into that EF of less than 55%, it's class 1. And the class 2A indication is the one where we have to be cautious, where we have to evaluate properly. There should be a compelling reason to do the TAVI. If they fail that class 2A indication, then yes, then we should wait. That's my take. Dr. Jessielyn?
Yeah.
So I think because the goal may not only be survival, it may be preservation of the myocardial health. So, fibrosis, diastolic dysfunction, cardiac damage begins before symptoms or even ejection fraction decline. So I think early intervention may prevent irreversible remodeling, reduce heart failure hospitalization, and eventually preserve the quality of life. So I think we may be shifting to from rescuing a failing ventricle to protecting the ventricle before damage becomes irreversible. And I think we also have to be very careful in evaluating not just age, but the life expectancy of these patients, because between roughly 65 to 80 years old, I think decision-making becomes individualized based on anatomy, frailty, coronary disease, valve morphology, lifetime strategy. But I think in older patients, early TAVR becomes increasingly attractive because of procedural recovery, symptom prevention, and quality of life may outweigh the long-term durability concerns.
Yeah, that's excellent. Maybe I'll shift to Hiroyuki a little bit, since you mentioned about perhaps we should avoid younger patients. Do you think with these the trials we have, let's say focus on TAVI, do you think TAVI device type matters? Because we know that if we're going to do these for assumption that it will prevent bad consequences, the result of the TAVI need to be quite excellent, right? So like
Yes.
low PVL, low pacemaker rate included, good gradient, no PVL, and so forth. What's your thought on device choice if we're gonna go ahead with this asymptomatic cases?
Definitely, we have the device choices would definitely depend whether you're choosing a tall valve or a short valve. Coronary reaccess in the future is very important. And I think one more important point in coronary reaccess, now that the technique is already starting to evolve, like the basilica strategy and the dedicated leaflet laceration devices are starting to be researched. I think early TAVR it's just a matter of time. I think early TAVR will push through, will be even more, give the operators more vigilant and more confident in treating these kinds of patients.
Maybe I can chime in here a little bit on what I feel about the topic. I think in asymptomatic severe aortic stenosis, I think the original criteria where you have a low EF or you have a critical kind of AS or BP drop during exercise and all that. I think these traditional criteria are still really forefront, in the decision when you want to intervene on a patient with asymptomatic severe AS. Then with the early TAVR trial, it comes whereby these guys are totally asymptomatic. They all had a stress test done. Majority had a stress test done, and it was negative. And so in this group, I think what the early TAVR trial kind of introduces is the idea that you could possibly intervene on them earlier. And this comes at the benefit of reducing heart failure hospitalizations, although not with a mortality benefit. So in my practice, I'm a little bit more nuanced in the sense that, in some of these patients, I do talk to them. I will let them know that, you could get admitted to hospital less. You may not necessarily live longer, but if you would like, I think it's reasonable. If you wouldn't, then I'll just monitor you closely. So I personally don't push super hard, in this truly asymptomatic group. But what I think this highlights is that this group really needs the physician to closely monitor them so that, in the event that they start decompensating, you are ready to intervene.
That's a good take, certainly.
Yeah. We have a cute question from the floor also. But before we get that, like maybe Mann and Jessielyn and all that, I'm just curious, so if your patient has asymptomatic severe aortic stenosis, do you stress test them? Or what do you usually do?
I don't. Actually, our practice is, I think if they are quite elderly and they are definitely severe aortic stenosis, and even though they're asymptomatic, I kind of had lower threshold to fix them. However, if they are younger, like Hiroyuki is saying, I think we usually follow them closely because I think lifetime management and second valve required is still an issue in the future. But no stress tests on a regular basis.
Yeah, I mean, personally, I don't really stress test my asymptomatic aortic stenosis that frequently as well. We do have a question from the audience, from Harris. So he's asking, if asymptomatic, do you need more information? What would you order? We kind of covered it, stress echo or cardiac CT.
So in my opinion, the anatomical factor is very important. So the anatomical factor allows us to do re-intervention like a valving bar, so we can progressively say the patient to do TAVI in the early stage. But in some complication will be hidden in the anatomical factor, or the valving valve is difficult. So I recommend you to follow the patient in carefully. Yeah. So yeah, that's my opinion.
Does that mean that shall we do CT scan TAVI protocol in this kind of patients early before we make final decision whether to intervene early or not, even though they're asymptomatic? Would that be your practice though?
For me, right now, as I mentioned, I am a little bit on the balance. So what I would do is I will actually talk to them first. So in those group of patients who are a bit more willing to consider early intervention, I do get a CT TAVI to kind of understand some of these anatomical factors that Hiroyuki has mentioned. For those that are really not to decide, in Asia it's a little bit different. Sometimes to convince our patients to undergo a procedure, they are a bit more willing when they have symptoms because that will make them feel better. And if they are feeling really well, it gets a little bit harder. So into a group of patients who are really prefer to observe closely, I generally don't get the CT in advance because I'm not sure when I will need to intervene on them, and I don't really want to repeat one down the road, and just because you are trying to minimize TESA. But that's just my own practice. I'm not sure what the rest of you all do.
Well, I agree with Jonathan because but there are some patients that are too anxious that really want to to have further workup, especially for CT, like especially for bicuspid patients, because we also have to make sure that we follow up their ascending aorta, whether it's already starting to dilate and whether there's an indication for a SAVR.
Raj, you mentioned about you looking at aortic valve calcium as part of your decision making, whether to intervene them early or not. Can you elaborate that for us?
Yeah, obviously, the first thing, as Jan was saying, I do CTs for these patients for two reasons. Because of the logistic reasons in India, some of these patients, they claim asymptomatic, obviously. Second thing is they want the procedure deferred for various other reasons as well, social and other reasons. And we had at least two patients waiting for some kids to come from US or otherwise when they were asymptomatic, and then suddenly they presented in a very unwell state. When you have the CT beforehand, when you have all the parameters, everything to hand, then it makes the procedure much easier or comfortable. When we don't have the CT scan, when this thing happens, even when this asymptomatic patient suddenly becomes symptomatic or acutely unwell, it becomes a difficult situation. Now, coming back to the calcium side of things, I do have the higher calcium scores, more than 2000, irrespective of whether it's male or female, then that's more than enough. If the patient, even if it claims to be asymptomatic, that's a good group, they will benefit. The reason for that is because I was in NHS before, obviously, Jonathan knows that, and the waiting list mortality was 3%. When the patients were waiting for 1 year, the waiting list mortality was 3% when they have severe AIS, irrespective of whether they have symptoms or not. And the procedural mortality is now less than 1% with TAVI. So we're comparing a procedure which is less than 1% to a waiting list mortality of 3%. When there is a calcium of more than 2000, those patients are a higher risk considered patients.
Great, thank you. I think for the interest of time, I think we had a good discussion on asymptomatic severe AS. Let's move to the next talk, also very, very interesting. Let me introduce Dr. Ivan Wong. He's from Hong Kong Asia Heart Center. He's going to give us a talk on TAVI for aortic regurgitation, dawn of the new era. Ivan, please.
Yes, hi. Can you see my slides?
Yep.
Yes,
we can
very
see.
well. Go ahead. Yep.
Yes, hi, thank you. Hi, this is Ivan Wong from Hong Kong. Is an interventional cardiologist, and it's so good to see so many of my friends again in this webinar. And thank you for the invitation, John. And topic of today is the TAVI for aortic regurgitation. So in fact, it's not that new, but I guess it still need a lot of the promotion or the education for these not quite aware, I would say, especially to the public, I would say, actually. So it's a good time to have these topic to come again. And actually, we know that for TAVI, for aortic regurgitation, is totally not a new thing. So we're talking about, we have done cases with TAVI for aortic regurgitation years ago. But the problem is at that time, so we have all the off-label devices. So all those devices are designed for aortic stenosis at that time. So for the problem of using those off-label devices in treating severe aortic regurgitation, the problem is because we are dealing with a totally different animal. Say, for example, for aortic regurgitation as compared to aortic stenosis, the leaflets, so we can see most of the time they are not calcified. And most of the time, also the aortic root is very dilated. And especially during the procedure or the implantation, we have a very high stroke volume that is difficult for us to have a very precise implantation depth or the location of our valve. So these are all the problems that we have in the past when we used these off-label devices to treat aortic regurgitation. So you can see from these pictures, sometimes we will end up with the valve embolized to the aorta, or even it would have the dive inside the left ventricle. So these are all probably we have seen these in the past. And these complications or these pictures are not only isolated cases. So we can see from these international or multi-center registry of the Pantheon registry. So this study with the off-label TAVI devices and is included 200 patients and use these devices to treat pure aortic valve regurgitation. So both self-expandable and balloon-expandable valve are used. And the study on is the incidence of the valve embolization and migration. So you can see these real-world data show that the incidence would be around 12% in the overall population with these embolization and valve migration. And the causes, of course, because of we mentioned the lack of the anchoring calcium or the malpositioning. And usually we have to do what we can do is valve in mouth, or the snaring, or use the balloon to reposition the valve, or even conversion to open heart surgery. And so, of course, we have a much higher complication or the composite endpoint. So all these message or the data would imply that we need the dedicated device for aortic regurgitation. If we're talking about TAVI and we're talking about moving to a minimalistic approach, so there is obviously is an unmet need. So I would use two cases to illustrate the usage or the different types of the dedicated devices for AR, and with these real life example. So for the first case is 70-year-old gentleman, so with multiple comorbidities, hypertension, hyperlipidemia, airway disease, and also coronary artery disease with previous PCIs. However, even after the PCIs, so he still has persistent symptoms of shortness of breath and the new heart class 3 symptoms. And you can see, so we have to repeat the echo, show that probably he has impaired air rejection fraction of 40 and some regional wall motion abnormalities, probably because of the previous ACS or the coronary episodes. And of course, we can say it's a definite severe aortic regurgitation, and with different parameters like the venous contractor, pressure of time, and the whole diastolic flow reversal. And otherwise, I have only mild MR and TR. So of course, we have to discuss all these cases within our heart team. And because of the multiple comorbidities and also the relatively poor ejection fraction, so he is deemed inoperable or high risk for the open heart surgery for the SAVR. So we have to bring him back for the consideration of TAVI. And you can see for the CT, it's a very typical case of these AR case. So you see it's a relatively large perimeter. The annulus perimeter is around 87. And you can appreciate the leaflet. So most of the time, there's only without or only very minimal calcium. And so you can anticipate if we use those traditional TAVI device, it still would be very problematic. And of course, we have all these peripheral access. And I guess most of you would know that actually for these AR case, pure AR case, most of the time the access or the femoral arteries are very clean, and most of the time they won't have any calcium or stenosis. So I don't know so AS probably is systemic disease or the systemic calcium. So of course, these are very clean. So so that's why we have to aim for a very good result, and we're looking for the dedicated device. So actually, this is one of the dedicated device that we all know is the JenaValve Trilogy. So actually, for these valve, the JenaValve Trilogy has received quite the CE mark quite a few years ago. So it's already approved in 2021. And mind you, that the JenaValve Trilogy is also CE mark for the aortic stenosis. So actually, it's indicated for both pure AR or even a severe aortic stenosis case. And the features, what you can see is the distinctive features is because it has the three distinct, very clear radio-opaque markers you can see in the X-ray. It's for the cups locator. So that's because of the cups locator, so it can grasp the native leaflet very strongly. That would prevent like the events of the embolization or device migration. And just that, probably you also know that this JenaValve also recently received the FDA approval this year. So basically, it's FDA and CE approved valve for the aortic regurgitation. So till now, the JenaValve is the only FDA approved valve dedicated for aortic regurgitation. So of course, we all apply the minimalistic approach in all TAVI cases. So for this would not be the exception. So we do the TAVI under local anesthesia, and we keep the access very minimal. So we only employ two access. So one is the radial access for the MP and AL1 catheter. So I will talk more about the why we use these catheters. So another, of course, is the femoral access for the TAVI is the Trilogy sheath. Is a 18 French and 22 French sheath, and is a sheath that would cross the arch. That I will show you later. And of course, we need quite a different views. So traditionally, we need the freecast view. Of course, the freecast view is for the deployment of the JenaValve. But of course, because we have to safely locate to make sure that the locators are in each cups. So we have to have more views. For example, the cups of left view and the isolated left cups view. So these are all predicted in the CT that we can use during the TAVI. So of course, this is the baseline aortogram. So of course, you have to confirm that these patients have the severe aortic regurgitation. So most of them, for these cases, we have to put the pigtail in the right cups, so it would be better to opacify because most of your contrast probably will lose to the LV. Another point is, of course, if the annulus or the cups are not clearly visualized, sometimes we need the rapid pacing. We do the rapid pacing such that we minimize the AR, and then we have a clearer annulus or the cups opacification. And next, so this is the sheath. So the good thing for this sheath is that it crosses the arch and would avoid a manipulation when the valve cross the arch. And you can see that at this point, you can see that we also exchanged that pigtail with the AL1 catheter from the right radial artery. It's because we do the cups injection. So usually it's the hand injection is very gentle to identify whether the locator is right in the cups. So we need the AL1 catheter, the MP catheter to subselect each cups, and then we have the hand injection. And of course, because of the features of the cups locator of this valve, so by design, so we have to achieve new commercial alignment. So for example, in the left hand side is the free cross wheel. So we have to make sure that the three radial-opaque markers are equally spaced. So they have to evenly distributed in this free cross wheel. And how to make sure that it is not correct or whether it's completely misaligned. So whether it's a 180-degree misaligned, we have to use another angle to confirm. So you can see in the right panel, so we have to use the cups overlap wheel. That's we have to make sure that because in this cups overlap wheel, the right cups and the left cups are in the right side of the screen. So if we have achieved conventional alignment, so both the radial markers, two of them have to be on the right side of the screen, and one will have to be left side of the screen in the non-cups. So we have to double check in two fluoroscopic projections. And of course, after confirming the cups orientation, so we can have the docking. So it's just a further advancement of the catheter. And this is what I mentioned is that we have to confirm each cups with the hand injection, save the non-cups, the right cups, and left cups, whether the cups locator is securely anchored at the cups base. So, and one personal tip is that the most accurate thing is we can see is the flaring. So when it advances, so we can see the locators, the radial-opaque markers flaring, and is anchoring at the cup space. So this is the most accurate method. So after confirming the cups locators, so we can have the deployment of the valve, and you can see is a very stable deployment even without any rapid pacing. So that's why we don't need any venous access. We don't need any crocodile clip pacemaker. So we do it with a very minimalistic approach. And this is the final aortogram. So you can see again in this free cross wheel. So we can see there is no residue PVL, and it's a very aligned with the three locators, equally spaced. And this is the echo state after. So you can see it's a very significant improvement. And actually, another thing that we have to mention is that during the procedure, actually, it's very convincing is that we always assess the systemic diastolic blood pressure. So in most cases, usually right before the deployment, the diastolic blood pressure would be around like 40 or 50. But right after the deployment of the valve, the systemic diastolic blood pressure will shoot up to like around 80 to 90. So it's a very accurate, again, reflection of the valve functioning. So that's for the case one is a very classical case of the valve trilogy, and is doing in a minimalistic approach. So we have the quickly go to the second case. So again, it's quite an elderly lady, and again, it's a severe pure aortic valve regurgitation. So it's class 2 new heart. And echo show is a air ejection fraction 60, and again have the features of the severe AR. And again, we discussed in the heart team, so this is a high surgical risk candidate, probably because of the age. So again, have to perform the TAVI for this pure AR case. Of course, our first valve of choice would be the Yenna valve. But you can see that for this case, when we perform the CT, so you can see that, well, for the aortic annulus, the annulus perimeter, you can see that is 104. So if you appreciate that, so for the 104, so even for the conventional devices like the Medtronic or the Abbott or the Edwards device, so all these the perimeter would exceed the recommended annulus range for these traditional TAVI device. And even for the Yenna valve, so for the Yenna valve, the upper limit or the recommended the upper limit would be around 93 or 94 max for the annulus perimeter. So for these cases, but it's surgically inoperable. So, and again, you can see that also is a type 1 bicuspid aortic valve, but it's a pure AR. So of course, for this case, then we have to look into another dedicated device. So you can see that for this is another dedicated pure AR TAVI device is the J valve. So it's first generation is a TA is transapical approach, and this next generation is the transfemoral device. So you can see it's quite different from the Yenna valve that it has the three claspers. It's not the locators, but these three claspers that they will have the auto alignment with the native leaflet. So we don't have the manually rotate or to adjust the claspers. So when the clasper descend to the leaflet, so they will automatically align to the native leaflet. And after that, so we deploy the valve. So this is the anchoring mechanism of this J valve. So you can appreciate that. So the point is because the J valve, just for the even you can see the 104 to 104 millimeters is already the upper limit of the largest valve of the J valve, but it's still is usable. So we can still use the J valve for these extremely huge aortic annulus. So therefore, so we again, so you can see that whether the J valve is approved or not. So for the J valve, the transfemoral J valve currently is approved by the NMPA. So it's the China's approval. Still don't have the FDA and the CE mark yet, but it's approved by the NMPA regulatory. So our plan for this patient again, so you can see is a minimalistic approach. It's a transfemoral TAVI under local anesthesia, and therefore we use the 34 millimeters J valve. And I won't bother you with the procedural image, but just want to see this is the final finishing aortogram. So you can see again, it's the three claspers in the native leaflets, and you can see there's no any residue AR or the PVL after the procedure, even for this huge aortic annulus case. So I guess, so this is quite a good summary of the currently available dedicated AR devices in TAVI. So as we have covered both the J valve and the Trilogy, and of course the Trilogy currently have the FDA and the CE approved, and the J valve have the NMPA approved. And for the J valve, probably it would cover the more of the larger annular size. And the upper limit for the Trilogy is around 93 millimeters. And but for the Trilogy, they have more. I would say is personally have the adjustable radial peak markers. But whereas for J valve, for the claspers, they are not manually adjustable. So we have to docking is quite is a self-docking mechanism. And so I guess of course there are still, I guess it's more and more of the dedicated device for the AR coming to the market. But of course these two are I think is the most representative dedicated device for AR. So thank you very much for your attention.
Thanks, Ivan. It was a really good lecture. I think at least in the region, Hong Kong and China probably has access to most of these AR-specific devices, and a little bit less in the Southeast Asia region. Maybe I could start with a question. Hiroyuki, you guys in Japan are starting some trials for the AR-specific devices. Have you had any experience with some of them?
Thank you for the question. So unfortunately, I have no experience for TAVI for AR, and maybe so there is no device for AR as of now. So that very interesting presentation. So I learned a lot from Ivan. So thank you for the presentation. So I have one question. So the J valve trilogy can be applied to the bicuspid valve. So
yes, so this is a good question. So for the probably for the type 1 bicuspid case, it's still doable. But for the type 0 case, I guess they are still cannot be, they are not recommended to use in the type 0 case.
So maybe to add on to that, Ivan, could I ask, have you had experience with type 1 and what it has been like? Was it with the J valve or with the Jena?
Yes, I have tried both for the type 1 bicuspid aortic valve, and there's not much issue because it's a totally adjustable for the Jena valve, say the radiopaque markers, so you can always adjust every time. So and for the J valve, as in the PowerPoint, so actually the clasper, so they also have not much interaction with the valve or also. So probably for the type 1 bicuspid aortic valve is feasible to do. Yeah.
Could I ask, since you had experience with both the J valve as well as the Jena valve, so I mean beyond the sizing issues, if it's a standard small to medium kind of annulus, what's your decision-making process on what type of valve to choose? Is one better than the other, or from your experience?
Yes. So personally, I guess it's for the learning curve. I guess for the Jena valve, the learning curve would be relatively easier because it's very systematic and very smooth, or is very how should I say? The technique is quite transferable. But whereas for the J valve, for example, that's still for the deployment of the anchor or the clasper or the is still quite there is a quite learning curve for that. So I would say if for example starting like a AR program, so it would be maybe easier to start with the Jena valve, I would say. Yeah.
Maybe a question to Mann and Jessielyn. Do you have some of these AR-specific valves available in Thailand and the Philippines, respectively?
I'll start with, no, unfortunately, we do not have any dedicated devices. So I have been doing TAVI in AR using a traditional TAVI devices. So we quite restricted in the case that it's completely inoperable and quite sick patients. We are quite successful. The not so good outcome is the pacemaker rate, because of with the non-dedicated device, then we tend to oversize a little more, and I think that's part of the reason why the pacemaker rate is very high. But otherwise, it works, but quite challenging and quite stressful to do it, as not much space to anchor. Yeah, but I also take with our dedicated device, I take special attention to the anatomy of the annulus and the LVOT and all that, just to make sure that the size is similar, like tubular shape LVOT. That also helps to anchor the valve properly.
Maybe I'll take you up a bit more on that, Dr. Mann. Like, so if you use the traditional TAVI devices, do you have a preference for a balloon or self-expandable valve, and how much oversizing do you usually
We have been using my experience is all balloon, using both Edwards and my valve. My valve come in handy if it's a very big devices. We have been using 30.5 and 32 even. The oversize, it depends on the shape of the LVOT. Usually I'll go between 10 to 15 to 20% oversize in general.
Okay. And Jessielyn,
Yeah, so I share the same sentiments with Dr. Mann. So we don't have a dedicated device for AR, but my experience with TAVR in native AR is with Evolut valve, self-expandable valve. So the main concern is number one is the sizing. So sizing is quite critical for these kinds of patients. So we usually oversize it even more than 25% for the Evolut. Our last case, we don't have a choice, but because the patient is already crashing, so we end up with using two TAVR device. So it's the TAV in TAV because the risk of embolization is quite high. So I also share the same sentiment with Dr. Mann. It's stressful. So yeah, so I hope the dedicated valve would be open to come to the Southeast Asia.
in Singapore, we have had some opportunity to use the Trilogy because it's CE marked, and it's a good valve, so it takes away a lot of the stress of the unpredictability. But we have a good comment in the Q&A as well. What is the pacemaker rate for some of these AR-specific devices? So for the IENA Trilogy study, at least in the published literature, the pacemaker rate is almost 1 in 4, about 22 to 23%. So it's also pretty significant. And from our limited local experience, we have seen a fairly high pacemaker rate as well. So maybe to Ivan, do you see such high pacemaker rates as well with some of these AR-specific devices, and do you have any ways to kind of reduce that AR rate? I mean the pacemaker rate, yeah.
Yeah. So yes, in the first few cases, so we also experienced is quite a high pacemaker rate for the IENA valve, and but then I guess they have modified a bit the sizing. So right now, I guess they would recommend that we have a minimum oversizing. So actually you don't need quite a high oversizing. And the second point is, and then we realized that for the radiopaque market, so the cups located. So actually you don't need to have that to be in the exact the base or at the bottom of that cups. So actually you don't need to go push very deep or very further. And then you try to achieve not a very deep implantation depth. So for these two ways, probably can reduce the pacemaker rate. But on the other hand, for the J valve, actually in the published data, the J valve, the pacemaker rate is relatively lower compared to the IENA valve.
Do you know what the rates are like for the J valve?
I would say it's still around 10%. Yeah.
Okay. Yeah, so to the audience, this pacemaker rate is at the moment one of the Achilles heels of the AR-specific TAVI devices. So I think with time and experience in techniques as well as potential modifications, improvements in the valve, we may see that rate come down as with the TAVI for AS. We have a question from Harris. In AS post-TAVI, there is worry of AR, and in AR, is AR still a problem after TAVI? What's the risk? I think, right, and maybe we can get some inputs from the panel as well as our speakers. I think right now with the new generation devices for TAVI in AS with the outer skirt and all that, the paravalvular leak or AR after TAVI has dropped significantly. And for the AR specific devices, the AR rates after TAVI is really, really low. So these devices really, if you size it properly, you almost get hardly any AR. Ivan, is that your experience as well?
Yes, yes, I totally agree with you, John. It's because as compared to AS, as I mentioned, it's totally different. So usually we do the AR case, pure AR case. So you don't have those calcium or all those leaflet issue that because you understand that for the topic of AS, the PVL or most of the time is because of these the calcium or the expansion or of these TAVI valve, right? But for AR is extremely rare. So most of the time for the AR case, you have a very good expansion of the valve, and also it's a very circular and very good outcome. So that's why for the really for the PVL or the residual AR is really not an issue for these dedicated device.
I had a question for Ivan. I mean, we are in Southeast Asia, more or less focused on aortic stenosis. But once you have the dedicated device in your practice now, do you have a lot of case referral for aortic regurgitation for TAVI? And do you foresee that could be like a big proportion of your practice in the future or even now?
Yeah, of course, because that's the reason that we have to have put a lot of effort to the education and the promotion, especially is to the I would say it's to the peer colleagues like the general physicians or the general cardiologists, because even I guess is some of them would not be also aware of these new technology that will be available. And for example, for those very old age or advanced frail patients, so most of the time they would also only opt for like medical treatment or conservative treatment, without knowing that there is still a very valid alternative for these patients. So, and and actually in my real practice is that there's, I guess it's quite more and more of the referral of these severe AR cases from the surgeon sometimes, or even from the cardiologist. So I would say that if these devices are available in your region or country, then probably I would say the TAVI volume would also rise at the same time. Yeah.
Yeah, thanks, Ivan. Do we have any other comments or questions from our panelists, speakers?
Can I ask a question?
Yes.
So in Japan, so there are many potential severe AR patients, but those patients doesn't meet recommendation like the symptomatic or low EF or large airway enlargement. So do we recommend, so like RE TAVR, so do you recommend JenaValve or JValve for those patients? So if if TAVI for AR is so the very good, so I want to do TAVI for those asymptomatic patients or those candidates who do not meet the server the recommendation. So yes.
Ivan, because of the new guideline suggests to use more quantitative way of confirming the severity of aortic regurgitation. For example, MRI instead of just echo, in particular in eccentric AR. Is that probably another talk, I guess, but do you need a lot of that if it's eccentric AR or still echo-based diagnosis for severity?
Maybe I will chip in a little bit here. I find, for the traditional transthoracic assessment of AR severity, there can be some limitations, and sometimes the AR is underestimated, as you mentioned, especially if it's an eccentric jet. I find actually CMR with those volumetric analysis being really, really helpful in further quantifying the severity of the AR. And maybe also a comment to Hiroyuki, because this we want to also teach our audience the correct things. So I think for intervention for AR, asymptomatic AR, we probably have what we have in the guidelines for now, meaning a low EF, really dilated LV or concomitant kind of operation. For TEVI, for AR in the first place, it's also not. It's also a bit dicey because the technology is not fully intervenient. So right now, really, it should be for patients who are high or prohibitive surgical risk. For low risk severe AR patients, the gold standard at the moment should still be surgery. And if you're asymptomatic AR, without all those factors like low EF and all that, then I think we really need to consider the risk of the procedure, before we undertake them. So we are coming up on the hour. Maybe I'll just do a quick summary of this session. We know that TEVI for AS is really very established. There's calcium on the aortic stenotic valves to be able to anchor these TEVI devices. But once we come to the field of AR, the leaflets tend not to be calcified. It's hard to anchor. And so really at the moment, there are two main devices, as Ivan has mentioned, the Jena Trilogy heart device, as well as the J valve. And so a lot of trials are ongoing with respect to these two valves. I think this space is really going to change, in the next couple of years. So it's really a space to watch. So with that, I would like to thank my co-chair, Dr. Mann, my two speakers, Jessielyn as well as Ivan, and our panelists, Dr. Rajaram as well as Hiroyuki. And thank you all, for listening in. Have a good evening. We hope you learned something. Thank you.
Okay. Bye-bye.
Thank you.
Thank you.